Okay, I'm Carol Levin. I'm a clinical associate professor in the Department of Global Health and affiliated with Global WACh, and a health economist, so delighted to be here. So why don't we get started? If you've ever, there's a good chance that a few of you maybe have seen some of what are in these slides. What I thought I would do today is really share what we've done as part of a project called the Global Health Cost Consortium, but not in a way where I'm going to tell you what the project was and the objectives. I'm going to sort of take you on a narrative, and what I hope by the end of the session you'll get an idea of what a good, what are costs, what's a good cost estimate, what are some of the outputs of our project. So that's where we're going today, and some of you know some of this stuff, and it's intended to provide it's really about resources. I'm not sharing any research per se, but rather a resource for all of you that are interested in incorporating costing into your work or need cost for cost effectiveness analysis for your work. So, and King knows this and Grace knows this, we were all fortunate to work on a project called the Disease Control Priorities Project when I first came here. And there is no shortage of studies on cost and cost effectiveness. Just to raise your hand if you've ever used this data in your own work to identify what works and doesn't work. Has anyone who here has used and read these articles? Okay, so there are multiple uses for cost data. So what we're focusing on today is the cost component. So for those of you that are epidemiologists, you know all about how to measure effectiveness. We're not going to talk about that today. My specialty is on generating information for costing that goes into priority setting, understanding resource requirements that's often used for advocacy that you see in the Lancet issues when you see, $1.2 million needed for so-and-so. Usually it's trillions of dollars. For donor and organizational financial planning and budgeting. And what economists really like to do is focus on improving efficiency. So we'll talk give some examples about that. So as part of the Global Health Cost Consortium, we actually did systematic reviews on HIV and TB costing data. So this is true for all domains, whether it's HIV or TB. This is true for maternal and child health, it's true for almost everything except for nutrition studies, but cardiovascular diseases, surgical costing studies. There are a number of increasing costing studies, and you can see the time trend. On the left is publications over time, and you get a sense, and this is for sub-Saharan Africa only, there were 157 studies that we were able to extract high-quality data from. And that's just for sub-Saharan Africa. So a lot of data is out there. Is it being used? Similarly, for TB costing studies, these are the studies that we extracted and included in what you'll see at the end of the presentation today in our unit cost study repository. We did a systematic review, and this is the trend in the numbers of studies that we found on TB provider and patient costing. Now, there's a lot of challenges in using costing data out there, and for those of us that use it or want to produce it, we have found this I've done a lot of work in immunization costing and a lot of work in cervical cancer, reproductive health, family planning. There's really very limited high-quality evidence in family planning. There's actually very limited information on TB costing. HIV has a ton of data. Why? Because we had such strong vertical programs there. But nonetheless, many of the estimates are kind of inadequate, and the earlier ones are of mixed quality. We have relevant data that are sometimes absent or not. They're not locally relevant. They're not quality adjusted. So a lot of, health economics has been growing, but a lot of people that conducted these studies may not have been economists, may have been doing it for the first time, doing the best they can, but there were no guidance documents out there early on. A lot of them failed to, even if it's a single intervention they're looking at, it's only a single platform. It may be at a facility or a hospital or one community-based strategy, and so we don't have information on the variety of delivery strategies. And the methods, there's just a lot of ways to estimate costs, and that's fine. But we found that there very little attention to doing it well and to actually reporting in a standard way. So why does this matter? You know, maybe many of you have found that this is true of epidemiological studies, that the quality is varied. I think that there's a lot more internal and external validation that happens in epidemiology. Costing has not had a science around it, really. But it does matter because donors are still trying to figure out what is the cost of ART treatment in a particular country. And this matters because UNAIDS asks the countries to create budgets for applications for funding. The Global Fund still funds a lot, and PEPFAR funds a lot of HIV and TB programs. And they want to know if their estimates are close. They don't have good benchmarks for comparison. Over time, if we don't have accurate estimates of the cost per patient reached or cost per ART treatment per year, we don't know if we're improving efficiency over time or not. You know, the prices are all over the place, so can't assess efficiency improvements over time, and we care about that. A lot of the things we do here in the Department of Global Health are aimed at improving the delivery of care, and so, you know, to assess whether these are more efficient or not than the existing programs, we need good data. And as I mentioned, donors, funders, and national finance ministers need this information. They want to understand through cost effectiveness if they're taking their, you know, as more donor funds come into a country, they're actually leveraging a lot of Ministry of Finance resources, and they want to be able to say, is this investment good value for money? So today what I'd like to do is, what do we mean by cost? So it's a little bit of cost 101. What do we use cost data for? What makes a good cost estimate? How can we understand if the analysis of cost estimate was done properly? And this is maybe the most important thing I can share with you today, is that the work we've done has provided a checklist. And I've used this I teach a principles of costing class, a 1 credit, and the exercise is to have, one exercise is to have the students compare 2 articles to our checklist. That alone is a huge value, even if you're never going to do a costing study. And then what is the unit cost study repository? That's the resource I hope that I'll introduce to you briefly. And where can you find more information on this kind of thing if you're interested? So what do we mean by cost? Very simply, a cost is really just places a value on a total resource used to deliver a service or an intervention. And ideally, what we want, what economists really want, is that cost to be equal to a quantity of the input times the price of that input. And there's all kinds of challenges why that's not as easy to get as you might think. But what we really care is about basically that cost for human resources, drugs and other supplies, equipment that are used to either deliver a test, to reach a beneficiary with testing, treatment, counseling for HIV or TB or any condition. So here's just a little exposure. I'm going to go over this fairly quickly, but we actually have 2 kinds of costs: financial costs and economic costs. Economists like to work in the economic costs. Financial costs are really just the actual expenditure, slightly adjusted depending on the objective of the study, on goods and services purchased. And often this is coming from our own projects, from our own expense reports, from NGO expense reports, or from the Ministry of Health budget expenditures. An economic cost builds on a financial cost, but it includes what economists call the opportunity cost of all resources used to produce a good or service. So I'm sure many of you know that in Global Health, we actually rely heavily on community health volunteers. Well, you know, if you looked at the financial cost, their value would not be included. So we want to include those costs that were donated, those costs that are a volunteer, and we need to have, those are all resources that are used. So one, if you use that resource if that were to ever transfer to the government, you would need to know what is the value of that service, right? You need the full economic cost. So let's just put that in practice. This is an example from TB active case finding. And this is a very concrete example of what's a financial cost and what's an economic cost. So in active case finding, they'll put a staff nurse closer to the community to try to screen, to try to identify TB cases. And so the financial cost is basically her salary plus allowances. But now she's, the economic cost is that she's now living somewhere in the community, right? And she has additional transport costs to do this. There's these lay volunteers, community volunteers, which I mentioned don't get paid, but the value, you would want to include the value of their time, and that will depend on where they live, what gender they are. You know, it might be that syringes, the price you paid, typically it's the price you paid. Syringes are pretty cheap. A patient coming in for the clinical assessment, financial cost is what they actually paid, but what if they had to get a babysitter? What if their time is now used to go to the clinic and they can't be doing their usual employment, whether it's own production in a rural area or in the informal sector or even in the formal sector. And then often an expert diagnostic kit might be provided, subsidized, but the economic price has to include the full unsubsidized price. And then again, you can just see with the computer. So that's the difference between financial and economic. So what are the cost measures that we typically think about? We typically think about total cost, which represent producing a service, the cost of active TB case finding for a clinic A, for instance. We often think about, we really care about average costs. And these are simply the total cost per unit of output, where the output can be measured in many different ways. It depends on the objective of your economic analysis. A marginal cost is the additional cost of producing one more unit of that good or service. So imagine that you already have a TB screening program in place. You right now reach 120 people. The marginal cost is what's the cost of reaching that 121st person. Now, an incremental cost, people get marginal and incremental, and incremental means now we're adding a new system, a new intervention to existing services. Let's think about, we have really well-established HIV counseling and testing, but now we want to strengthen assisted partner notification. That is a new intervention to an existing service. What is the incremental cost of adding assisted partner notification to current services? So what do we use cost data for? These are just illustrative. One, as most of you know, we do use them for economic cost effectiveness analysis. We use economic costs for cost effectiveness analysis, where we look at the total incremental cost associated with the net benefit. Net benefits can be a death averted, a disease averted, an aggregate measure like the disability adjusted life year, the DALY, or quality adjusted life year, the QALY. We can look at disaggregated costs, and we want to understand, for instance, here's a study of, I think it's TB costs in 3 countries. We want to understand what's the variation of, in cost across settings. And you can see we can break that up into capital costs, personnel, test kits, supplies, and supply chain costs. And then again, I mentioned this already, but cost strategic planning models, which are used to support PEPFAR, Global Fund, Gavi, they use cost data in a range of pre-existing models. The Spectrum, there's a Spectrum set of models which are available online that are developed by Avenir Health. They have these resource needs models which require cost data. There's the Asian epidemic model that requires cost data. There's now these optimization models, Optima TB and Optima HIV, that require cost data. So these models often have cost data in them, but they're old and they may be wrong, right? So how can you improve the data? Your users can change them, but with what? And then we really like to look at scale efficiency, right? So as we increase the number of beneficiaries reached, what happens to that cost per beneficiary? And typically what happens is initially you have a bunch of fixed costs like equipment and startup costs and training. And of course, the more clients you reach as you go along that x-axis, for a while that cost per person is going to go down. But then what happens? You have to get to the hard to reach individuals. And you can see that then perhaps you have to get more vehicles, or maybe they live farther. And so you're doing outreach to access them, and suddenly you see that cost per beneficiary is going up. So understanding scale is really important for us. What makes a good quality estimate? And we think that we've developed this, and I'll talk a bit more about it. in 2 slides, this Global Health Cost Consortium reference case, and we think that we're going to make a big contribution to improving quality cost estimates. And what makes a good quality cost estimate, recognizing that people have limitations on their budget, on what they really can collect, is making data generalizable, transferable, and consistent. And so obviously, if you want to meet statistical properties, you want to have more precise and more accurate cost estimates, you might need to have large samples and a lot of money to collect this data. But other properties are really important. They need to be transparent, it needs to be reliable, it needs to be consistent. And so what we want to do is not start to put up bars like you have to have n equal to 30 to 50 to do a costing study. We want to encourage people to follow best principles when conducting a large or a small costing study. To do this, we've developed, and this is online, it's called the GHCC reference case. It's a set of guiding principles to improve cost estimates. It's not a methodological document. There are plenty of textbooks and resources to support that. But what it does is it sets out a set of 17 principles, and then under them, it sort of says, here are your methodological choices, and we may go so far as to recommend certain standards, so that would improve generalizability across studies, but by no means are we prescriptive. And again, we've also set some minimum reporting standards, and we've generated a checklist to help people that are conducting cost studies to go through them and say, did I do all this? And would somebody else be able to follow what I've done? So let me just quickly go over the principles very quickly, in part to tell you what they are, and in part to impart a little knowledge. The first one is around study design, and I think we can all agree whether or not we're doing an epidemiological study or an economic study, we have to define the purpose, and purpose dictates method. I think that's a sort of conventional wisdom. So what's different in costing is we really need to understand whose perspective. And that means, is it the perspective of the donor, the payer? Is it the perspective of the health system? Is it a societal perspective where we really care about not just the health system, but the patient and even other sectors? Societal means we care about, if I use resources to provide these services, they are not available anywhere else in society. And we want to understand that perspective as well. Is it the patient perspective? Is it the household perspective? We want to understand, as I mentioned, whether it's financial or economic, that if studies don't indicate that to you, it's a big gap in how they describe their methods. And are they doing real world, or are they kind of doing, well, you're supposed to follow this HIV protocol, and that's what we're costing the guideline, not what we observe. What are the cost measures, what's the unit of service, and what's the time horizon? So again, this has to be clearly defined. So let's go to an example. So there's the cost effectiveness of TB active case finding. Most ministries of health would like an economic evaluation for that, and so you would use economic costing because you want to capture the true value of all resources being used. It would be real world costing to see what is actually occurring. It would be incremental, as most cost effectiveness studies are, because you should be comparing current practice to something different, or you should be comparing alternative strategies, and that makes it an incremental cost effectiveness per net benefit achieved. And the time frame has to be long enough to see all the benefits, the long-term stream of benefits. Now, if you were doing a budget exercise for ART and District Q over the next couple of years, you could do a provider perspective, so you're interested in financial costs. Real world costs would be accurate, but it could be costing the guidelines. And you'd want the full cost of the services, and if it's a 2-year budget time frame, the timeline is 2 years. So that's what we mean by clearly articulating the study, the scope. Yeah, sure.
It's about the real world costs. I mean, if you were, say, on this side of the
Well, I think it'd be hard to do a costing study on this side of the Atlantic, depending what you're doing, unless you're modeling and you need some cost estimates. So I would use the literature in that case. I think it'd be really hard to do costing remotely, unless you've got somebody on the ground or you're working with someone. Is that what you mean, like if you're modeling, or?
Say if you go from here, like if I go from
Okay.
here to
Oh.
country X,
Yeah.
that I'm not from,
Okay.
trying to find information that is relevant, I guess, it will require somebody who's local, you know what I mean?
Yeah.
So if we don't have that, or if we have limited access to that, then what? I
That-
think essentially I'm asking what the minimum standard is
Yeah.
for real world cost.
Yeah, that is I can answer that. It's great. I mean, we do that, and we go, and you have to set up your study in such a way that you are partnering with a local health economist. We have been collecting data from, settings. It's pretty easy to do, so happy to address that more. I mean, that's the work. So right now I'm just going over the principles, but it's A-okay to ask that question, but it is really possible. Ariana's done that in Nigeria. I've done it in many countries. So let's talk about that afterwards.
I thought you were raising the question of graft and corruption, and maybe you're going to get
Yeah,
to that.
that's interesting. So I thought you were going to ask more something like, what goes in real world costs? And honestly, if you knew about graft and corruption, you would probably want to put it in there. The chances are you won't know about it. But you will see inefficiencies. And that's a big question. It's like, do I include the fact that they don't have, and this is a true story, they aren't using syringes to withdraw blood for rapid syphilis testing. They're using a scalp vein set because that's all they have here. Do I include the $2 instead of the 5 cents? That's a good question, right?
The Gabby case is famous for the amount of extra cost that came from stealing, basically.
Well, yeah.
In Gabby. And then Patty Garcia, who's here this week, gave a lecture recently at the Consortium of Universities for Global Health on corruption.
Yeah.
And she made the case that in Peru, a huge amount of the costs for corruption. So those are factors that are hard to calculate.
Yeah, again, I'm not highlighting this as much as I should, but the objective of your study should dictate what you do. And so if the objective is to understand what was spent on a project that's completed and there was graft and corruption, you'd want to try to get that. You won't. Who's going to admit to that? So, anyway, they can barely, but I'd love to talk to you afterwards. So I don't want to brush off your question, but it will take another 4 hours if you have that. Okay, so maybe some of this will help. So how do you start your, after you have defined your scope, you have to measure resource use. And so this starts by this is the part that starts here in University of Washington, working with your colleagues. In any country setting where you describe the intervention and the program fully, you have to understand the activities for the specific intervention. You have to identify all the inputs that are required, and you have to understand the outputs. Health economists work closely with epidemiologists. We work closely with those that are doing randomized control trials, process evaluations, impact evaluations. We're rarely going over there in this setting, in our academic environment, or even in PATH. We're rarely going over there just to do a costing study that's not integrated with some kind of intervention. So the Global Health Cost Consortium reference case framework tries to help us get to a standard unit cost. And a unit cost is simply that total cost over total output. It can be defined in many different ways, and you'll find more about that in the reference case. But what we're basically doing is identifying direct service activities, many of those ancillary service activities that have to occur in order to provide the service, but don't happen at the clinic level necessarily, supervision perhaps, supply chain logistics, surveillance. And then what we want to do is find out what those inputs, resources, and prices are. I told you ideally quantity times price, but in practice the best we can do is use expenditure data. So here's an example of that for TB active case finding, where the direct service is, the number of visits, the quantity of visits, and that cost per household visit. So you have to estimate that cost per household visit, and that cost per household visit is going to be personnel as well as personnel time in this case. It will also require, there's a cost per outpatient visit, and that requires personnel and infrastructure. Ancillary costs in this case are community events to raise awareness, and then of course the test kits and the cost per test. So you need to understand the cost per test times the quantity of tests you use plus the cost per test, right? So this is just one way to break it down, to understand, figure out what you're doing, and then get the P's and the Q's all lined up.
And Carol, when would you consider the indirect cost to the patient for something like this, so like time off work?
Yeah, this.
Would you only consider that if you're taking an economic perspective?
Yes. Okay. Yeah, and that could have been in here, but it's not. So in a previous example up above when you came in, it wasn't. Okay. So so again, I talked a little bit about sampling, and I've to date done small, I've often done small facility sampling, and we do that here. Why? Because often we're only working in 20 clinics in a country. Sometimes you're only working in 4 for randomized controlled trials. So sometimes we can't help but work in a small sample. But as I mentioned, if you really want to understand the cost of perhaps something like ART globally, then you better, or the costs of TB screening, and you're doing a multi-country study, then you may need larger sample size. So sampling can be at the individual facility level. It will, again, the sampling frame will be determined by the precision needed, and by your budget, and by what you're integrating costs into. But again, whatever you do, just say what it is. You know, we're okay with just about anything. Purposive sampling, we want to avoid opportunistic sampling, but purposive can look a little bit like opportunistic. But we want it to be clear what you did. So here's, so then the next thing around collecting cost data, are there different methods? One is micro-costing or gross costing. Micro-costing is where you actually go into a facility, you find out what everybody's doing, you kind of measure the quantities and later get the prices associated with all those activities and inputs. What we often really do is what's called gross costing, and we use available expenditure data. In this case, imagine that we're costing HIV counseling and testing in a particular facility. There are many departments in that facility, so we understand what is the full range of costs for that facility, and then we sort of use a method called step-down costing to allocate what's going to the HIV clinic, and within the HIV clinic, what's going to HIV counseling and testing. That's an example of gross costing, yeah.
Is micro-costing considered more rigorous because it's like prospective?
Micro-costing could be retrospective, believe it or not. It is more rigorous because you have to understand the quantity of resources, meaning you don't just get the expenditure data. You know, no matter what, you have to interview people to understand how to allocate resources. In reality, we do a mix of gross and micro-costing. So it basically means in practice you go to a facility, you meet with the clinical providers, you meet with the administrative staff, and you piece together whatever you can. So I wouldn't say it depends on the size of your sample, but it's all, I think you can usually think about spending a couple hours at a facility, and a good chance you might have to come back for follow-up information. But it is typically more demanding. So measuring outputs, as I mentioned, we work in the context of broader evaluations, and so often the outputs I take and the outcomes are coming from an evaluation team. And so again, they occur at different levels, they mean different things. They're not always standardized for costing, and so the reference case is trying to move toward a set of standard units, and we have guidance on that. So we have standardized units for HIV. What does that mean? It's like we're going to tell you what we think should be in an average TB test, an average HIV screen. We're going to tell you what components we think should be there. If you don't meet it, then you can say, we omitted these costs because we couldn't access them. Again, understanding the source of your data, reporting the approach you use there will be missing data, justifying your approach, where it's not dictating, it's not rigorous, it's just asking for transparency. So I'm not going to dwell too much on this. you know, after you quantify your resources, you have to value them. Again, I've talked about the difference between financial and economic. All costs typically are converted to a constant US dollar. So there's some work around converting local currency units to US dollars. That's pretty straightforward. If it's a multi-year project over 5 years, you might have to deal with inflation, right? So that can make it a little trickier. And you know, it's always good to actually present your information in local currency and US dollars if you can. So then in the analysis, again, I'm not going to dwell on this, but the reference case provides guidance to explore heterogeneity, and I'll tell you what I mean by that, to characterize uncertainty, right? And to communicate the results transparently. And this is perhaps if people just do this, we've done our job. So has the heterogeneity been explored? If you only have one cost figure, have you looked at the differences between technology, between service delivery platforms, between target populations, geographic areas, seasons, right? A single cost point, no one will believe that's you know, so, you know, we're kind of limited, but to disaggregate as best as you can. So here's an example. It's not HIV or TB, but it's from some of the work I did on HPV vaccination, which explores actually the cost per dose. It's the cost per dose delivered, believe it or not, and this was many years ago when HPV was first introduced in a demonstration project between Peru, Uganda, Vietnam, and India. It's the economic costs, and you can see that it's for a variety of platforms. In Peru, it's the school-based. In Uganda, they did school-based and child health days. In Vietnam, they did school-based and health center-based. And in India, they did campaign and routine. And so you can see that presenting your data like this helps a user understand, like, oh, costs are different not only across countries, but within countries. And what is characterizing uncertainty sounds a little scary, you know, because especially since we sometimes say sensitivity analysis, but it really means that we just need to, if there was a cost estimate or parameter estimate that you weren't quite certain about, and you didn't think you measured it very well, you would want to talk to, you'd want to gather other information to try to set upper and lower bounds, and then vary your analysis by just increasing it by 25% or lowering it by 25%. But just, there are actually nice software packages that help us do this, to look at what if I change one variable at a time, what happens to my total cost, what if I actually change a lot of them, and what are the biggest drivers of my costs. And so we need to characterize that, and we need.
Would you usually report sort of a best case scenario, worst case scenario?
You would,
like your
you repeat it all.
average?
And if you can get these software packages, which I'm completely spacing out now, not triage, it's a different one. Crystal Ball, they're the at risk. There are 2 packages that you can eat. Well, you have to buy them or obtain them on trial. They will actually do the analysis for you. They'll run Monte Carlo simulations and generate tornado graphs. It's really nice, but nobody has that around here. Okay.
How expensive are they?
Well, it'd be good to get one. They're maybe $5, you know, through campus, maybe $600-700. It would be worth having if we could somehow figure out how to get a departmental one that we could loan out.
We should see if CSDE could put
That would be great. To get at risk and crystal ball and triage would be a huge asset for us. Yeah, a kind of communal thing. So now, up to this point, I've been talking about kind of costing 101. A lot of what I just went over is in our Global Health reference case. It's an awesome document. It's online. You can use it on a phone. You can download the PDF, and so I encourage you to explore that. Now, another main objective of the Global Health Cost Consortium, which is coming to an end in July, and so is a unit cost study repository. It's been designed to generate high-quality cost data that are consistent with the reference case, right? And so what is it? It's actually a nice tool. It is, in fact, we heard recently that Joe Dillman over at IHME downloaded all the TB costing data. One of his students is going to use it. Pretty excited about that. So it is, I told you we did these systematic reviews of cost data. We extracted them in a painstaking manner. We made sure that we were comparing apples to apples in all of these costing studies, and then we loaded it into this unit cost study repository. And so it's, we have 2,577 unit costs from 350 studies for HIV and TB, and that's remarkable. And they're all in US 2017 dollars, I think. Now, mind you, some of the things we're not even doing anymore in HIV, right? So, I mean, things are moving so fast. Differentiated care, home-based care, you know, we've tried, we're as up to date as we can, depending on whether costing studies existed. And just to give you, so you can choose your intervention in step 1 and view results, and you can't see this very well, but it will just present all the results. You can drill down and see as much information for a single study as you like. You can click on any single row, and it's going to tell you exactly what is in that cost estimate. But the nice thing, the improvement to this, is you can now visualize the data. So this is for, this is an example from, it's a little hard for me to see, sorry. It's an example of cost studies for, I should have made this bigger, I just dropped this in today. Can anyone read that?
You mean the countries?
Yeah, well, I can see I know what the countries are, but I can't see what the, oh yeah, for VMMC, right. So this is for 4 countries, unit cost for VMMC, and they tell you what the mean is and the variance. So you get to say, wow, I don't think I want to use any of that data. It doesn't look very consistent, right? But it's your choice as a user to either take an average of this, to choose one country, or not to use it all, but it is what's available to you. And you can assess the quality. We did a quality rating. We flagged when there's issues with the cost estimate. And then you can also look at, we present it in many different ways. We have a heat map, so you can see how much data is available, but I didn't show you that because the graph didn't turn out, it wasn't visible. And this is just other ways to look at data, other ways to see what the data are telling us.
Is there a way to see what the cost drivers are so that you could go back one to
Yeah.
see, like,
You would,
in my case, more like...
Yeah, you would go into this top page and drill down. Yeah. So that's what we've done. Again, I think you can, I'd encourage you to go online to ghcosting.org and fiddle with the unit cost study repository. If it's not easy to use, we are open till July and are still making tweaks to it. We've beta tested this on many different occasions with different users. And I think you'll find it pretty useful. And just in the slide set, which we'll be distributing, there are other sources for costing and guidelines, and then also we have a reference case checklist and a glossary of terms on our website. So again, that's it for now. So we have time for questions and conversation, but feel free to explore and contact me with more questions.
Sure, will that get updated in the future? Like, will somebody try and...
That's a good question. So that's a great question. Originally, we had a lot of interest. We had a big focus of our original grant was on sustainability. And interestingly and truthfully, World Health Organization, who we engaged with very early on, really didn't show an interest in this. And it was our hope that they would, and we could find someone. So the group that you guys work with, Cheryl Johnson, you know, one option is to maybe try to explore with her. But the challenge is the Gates Foundation has sort of lost interest in this. And I think they've lost interest in it as their management has changed. It's really hard to know what's going on there. But they were very concerned with making sure that this information would be used. And we spent a good 18 months trying to convince them that it would. And in the last 6 months, they've just not been helping us to do that. And so then they said that there would be a follow-on, but it had a 50% chance of getting funding, and they couldn't be sure. And so we were getting really mixed signals.
But since Joe Diedelman is using it at IHME and Health Metrics often has costing,
Yeah.
it just feels like through there somebody would want to...
If we could, and maybe I would start to talk to them, because it's not trivial extracting the data. You need a team of people to extract the studies, and then you need, we want to continue working with Avenir because they've established a programming to get from, you know, Excel data to a flat file, upgraded, cleaned. It was not trivial.
But IHME does non-trivial data.
Well, that's a great idea.
You could talk to Chris.
What a great idea. I'm going to pursue that because this is an amazing resource, right? And our hopes were that we would apply it to malaria, to NCDs. So again, maybe it'll come into vogue, and it could be, maybe there will be another group, Avenir and London School will carry it forward, but it's been kind of quiet on the foundation front, and so that doesn't go on the recording. Stephanie.
Yeah.
Yeah. I do also want to acknowledge that these slides are, we are developing a couple of YouTube slides that will help people use this, and that I drew slides from a World Bank GHCC presentation, a learning module, which is available on the website. So you can look at this one, but you can go to our website and see some